And we move on to the second session, that's State-of-the-Art Lecture STEMI in India. We have two presentations for 20 minutes each, followed by 5 minutes of discussion. Professors Lekha Pathak, G.S. Wonder, Dr. Brian Pinto, and they haven't been able to make it up. May I invite Professor Satyavan Sharma and Dr. Ravinder Sambi to please join the proceedings. As the chair, Dr.P.P.Mohanan, who is Director and Head Department of Cardiology at Westfo High-Tech Specialty Hospital in Trichur, Kerala, for 20 minutes.
Good morning, ladies and gentlemen. It's really a great honor for me to introduce a person like Dr. P.P.Mohanan, who is the organizing secretary for the next CSI conference at Kochi. And he's come all the way to discuss on a very, very important issue on oral anticoagulants. In fact, for the last 2 days, we had a lot of discussion on oral anticoagulants, especially in a setting of atrial fibrillation. Which agent to use, when and for how long, which is costly, which is cheap, which is very important to prevent the stroke. Ladies and gentlemen, without wasting any time, I present to you Dr. P.P.Mohanan. P.P.Mohanan, sir.
Thank you, sir. Distinguished Chair. At the outset, I should have an apology. I will say that I've gone through the scientific program and found out that so much has been discussed on atrial fibrillation and NOACs. So the newer oral anticoagulants. So what I will do in the next 10-15 minutes is confine myself about the utility of the newer oral anticoagulants in the setting of an acute coronary syndrome. I will not be touching on NOAC's role in atrial fibrillation. I have nothing to disclose except for the fact that I've been involved in some of those trials, like RELY AF and Aristotle and the Engage AF. This was said, centuries ago, but I suppose this is very, very valid right now, because so much has been, the stupendous advance in the management of acute coronary syndrome over the last many years, whether it's in the form of the newer drugs, newer devices. The intervention has its mark already, but whatever it is, it's ultimately the thrombus which makes the most difficult thing in the acute coronary syndrome. Whether it is an occlusive thrombus, whether it is a non-occlusive thrombus, it is the one which is the cause of genesis of an acute coronary syndrome. And understandingly, we have an array of parenteral anticoagulant drugs which all of us have been using in the setting of acute coronary syndrome, right from unfractionated heparin to the low molecular weight heparin to fondaparinol and of course to bivalirudin. Unfortunately, Wonder is not there to discuss about bivalirudin. So we have been using the parenteral anticoagulant drugs over the last many years very, very effectively. I just want to again put your attention on this clot business, mainly because now we have a very potent oral antiplatelet drugs. But again, it's basically the role of thrombin, which is again making the clot more visible, more aggressive. And here comes the role of the anticoagulant drugs. So we have been using warfarin and other vitamin K antagonists sparingly in the setting of acute coronary syndrome, and last few years has seen the intrusion of the newer oral anticoagulants drugs, not only in atrial fibrillation but also in the setting of acute coronary syndrome. This is what I was mentioning, the update as early as in the early 2000s has given a class 1B recommendation for the use of warfarin along with either a single antiplatelet drug, aspirin, or a dual antiplatelet drug, aspirin plus clopidogrel plus warfarin, the triple drugs. Only thing is, one has to be extremely careful when you combine a dual antiplatelet drug with the oral anticoagulant drugs like Warfarin, and you have to be not very aggressive like what you do in a case of atrial fibrillation, when you may stretch the INR even up to 3 or 3.5. You have to keep the INR to something in between 2 and 2.5 when you combine a dual antiplatelet drug and warfarin. Obviously, because as you can see in this slide, and you can see that warfarin itself causes significant bleeding, more so when we combine warfarin with either aspirin or clopidogrel, and all the more. Now you can see that the triple therapy of warfarin with aspirin and clopidogrel causes phenomenal, maybe about 3 to 4 times the incidence of bleeding when you put the patient on the triple therapy. Again, many of you who have been listening to the last few days of the proceedings would have gone through these the newer oral anticoagulant drugs. You have a lot of them, not only parenteral but all the oral drugs. And basically, we'll be confining ourselves to these 3 drugs: the direct thrombin inhibitor, the thrombin inhibitors dabigatran, and the factor 10A inhibitors apixaban, rivaroxaban, and edoxaban. All the 3 of them has been approved for treatment of atrial fibrillation. Well, I mean, there are some pharmacological differences between these 3 important drug group. As you could see here, the dabigatran principally is a thrombin inhibitor, while rivaroxaban, the bands are basically a 10A inhibitors by the gatran. Earlier we have zimelagatran, which has gone out of vogue now because of the excessive liver toxicity. So the gatrans basically attacks the factor 2 thrombin, and the bands, the apixaban, edoxaban, and rivaroxabans, targets on the factor 10A. The half-life is almost similar. There is not much of a difference except the fact that basically you give rivaroxaban, especially when you give rivaroxaban in the setting of an atrial fibrillation, you do it once daily. All the other drugs are twice daily drugs. The clearance part is a little different. Dabigatran is basically mostly cleared by the kidney, while the apixaban is mostly cleared by the biliary route. You have a sharing by the renal and the liver for rivaroxaban. This was what you have listened to in the last couple of days. You would have listened to all these trials and their value in the management of non-valvular atrial fibrillation, and that's why I said I have no intentions to bore you again about the usefulness of NOACs in the setting of atrial fibrillation. We have huge data available in the form of umpteen number of trials, which has proven the value of NOACs in the treatment of atrial fibrillation, especially non-valve atrial fibrillation. Now you have also the recommendations by the major cardiology bodies like the ACC/AHA and the HRS, which gives a class 1A recommendation for, class 1B recommendation, for dabigatran, rivaroxaban, and apixaban in the setting of atrial fibrillation. What about the newer oral anticoagulant drugs in the setting of acute coronary syndrome? Now, this is a totally different kettle of fish. We have few data, and that's why we don't have a consensus on the value and the use of the bands or the gatrans in the setting of acute coronary syndrome. I mentioned about the zimelagatran, and we have a short study, about 2,000 patients, was done in the ESTEEM study. It has to be discontinued mainly because it is found that zimelagatran causes excessive liver toxicity, so that is out. What about the other groups of drugs? Like dabigatran was given in the REDEEM trial, a 3,000 patient ACS patient data set, where dabigatran was given as 110 milligrams and 150 milligrams twice daily on the 14th day of ACS. We should realize that despite all our very effective antiplatelet drugs, Even now, even when we use prasugrel or ticagrelor or whatever, or the potent anticoagulant, parenteral anticoagulant, even now the in-hospital mortality or the 30-day mortality is pretty high. The MACE rate in the first 1 year is something to the tune of 15%. Even in the GRACE registry, one of the largest registry, which is about more than 100,000 patients, the 5-year mortality is about the tune of 20%. With a 5-year recurrence rate of MI after an ACS is 9%. So we have a problem in our hand. Despite the potent antiplatelet drugs, we still have residual ischemia happening, MACE is happening. So it is mandatory that we use the newer drugs also in the setting of acute coronary syndrome. The REDEEM trial was one of its aftermaths, but unfortunately the REDEEM trial again did not show any significant reduction in the cardiovascular mortality or the MACE rate, and it caused excessive bleeding. So dabigatran cannot be suggested in the setting of acute coronary syndrome. The other two molecules, the apixaban and rivaroxaban, we have more data coming up. The apixaban was tried in the APRISE 2 trial, 1 and 2 trial, where apixaban 5 milligram twice daily. Mind you, this is the same dose that we give in atrial fibrillation. This is again, the idea was to recruit about 10,800 patients. But the trial was stopped after recruiting about 7,000 patients, for it was found that there is an excess bleeding in the appraisal trial. So apixaban right now is not recommended for use in the setting of an acute coronary syndrome. So that leaves us to only rivaroxaban, which is tried in the ATLAS-TIMI trial, which again is a huge trial. And again, you have aspirin alone, and then aspirin plus clopidogrel plus rivaroxaban. Rivaroxaban was tried in a smaller dose. See, it is not as you could see the difference between the APRISE trial and the ATLAS-TIMI trial. You could see the difference. There are some differences. It is not possibly easy to compare these two trials. One is APRISE is a high risk group, and the drug was used in the same dose as an atrial fibrillation. Look at the ATLAS-TIMI trial. Here is again, it is not a very low risk group, but APRISE has a high risk group. Here the dosage of rivaroxaban was almost 1/3 or half of the dose. Here it was used in the form of 2.5 milligram twice daily or 5 milligram twice daily. The APRISE was stopped early after recruiting about 75% of the patients, while ATLAS-TIMI with rivaroxaban was completed. And right now, rivaroxaban is the only newer oral anticoagulant approved only by the European Union. The FDA has, the US is still to approve possibly rivaroxaban, and maybe it will happen soon. So this is what the difference made was, you could get, whenever we use any antithrombotic drug, be it an antiplatelet drug or an anticoagulant drug, basically we have to do a balancing act between reducing ischemia and reducing bleeding. So here, when people used rivaroxaban in a smaller dose of 2.5 milligram twice daily, the incidence of bleeding, major bleeding, was considerably lesser. And that's why possibly the European Union also approved that. And we have a meta-analysis of all the newer oral anticoagulants in the setting of acute coronary syndrome. And this is the last, you could read the last conclusions. There's a modest reduction. It's a reduction, even though it's modest. There's an increase in bleeding that you cannot take it away from any anticoagulant drug. And interestingly, you have almost similar results when you combine rivaroxaban with aspirin or rivaroxaban with aspirin and clopidogrel. Well, again, you could pay your attention to these two p-values. You could see that there is a statistically significant reduction in the composite ischemic endpoints, but there is also an increase in the TIMI bleeding. This is what I said. The European Union and approved given a class 2B recommendation. It's not a class 1 recommendation as you would have seen in the case of Warfarin post-PCI. This is a class 2. But of course, we are in the earlier days. It may progress from class 2 to class 1 later, but right now, the European Union has given a class 2B recommendation for selected patients. For example, patient with a thrombus, patient with an atrial fibrillation who comes with acute coronary syndrome. There are very many settings when one may use an oral anticoagulant and antiplatelet drug. So, rivaroxaban is the only newer oral anticoagulant which has been recognized at least by the European bodies. But these are different times. Many of us are now gradually navigating into the newer antiplatelet drugs like prasugrel and ticagrelor. What about the data of rivaroxaban or eniban with the newer prasugrel or ticagrelor? We don't have much data. Only very, very scanty data is available about that. And this is more of a network meta-analysis. More of something like, now, you don't have a direct comparison between prasugrel and ticagrelor. So people try to do a network meta-analysis or a pharmacodynamic analysis and come out with saying that, oh, ticagrelor is better than prasugrel. Almost similar way, this was a network meta-analysis in which they found that maybe it's a good idea to combine ticagrelor, which is the only antiplatelet drug which reduces total mortality. No other antiplatelet drug reduces total mortality. Ticagrelor is the only antiplatelet drug. Maybe it's a good idea for us to combine ticagrelor with rivaroxaban, but it is an idea. Right now, we may need more data to suggest this combination in the years to come, and I'm sure this will come soon. So, gentlemen and ladies, thrombosis is a critical issue in every cardiovascular disease, and especially so in acute coronary syndrome. And reducing thrombosis is possibly the most important thing that we physicians should attempt. There are very many pathways and drugs available to reduce thrombosis. Long-term combination of the newer oral anticoagulants, only rivaroxaban, that too with aspirin and clopidogrel, are only available. We don't have any data on the newer antiplatelet drug combination with the newer anticoagulant drugs. The widespread use of these agents, as we go on and as we have more data coming up, I'm sure there will be more wider combination available or wider use of these newer anticoagulants and new antiplatelets, because there is still a residual problems in coronary artery disease after ACS. So we have to be absolutely careful. One has to do a balancing act between the risk of ischemic events and the risk of bleeding. Thank you very much for your kind attention.
Thank you, Dr. Mohanan, for a very excellent review and up-to-date information on combining these two agents. Is there any question from the audience?
Nice lecture, sir. It's well known that the strands can be used in DVTs. Can these other drugs, the bands can be used in DVTs?
Sure. They have been recommended in DVTs, pulmonary embolism, and atrial fibrillation. All the dabigatran and the bands.
But they seem to be more costlier. Could there be any benefit out of these trans when compared to the bands in DVTs?
Well, the white man has done a cost analysis and has said, I mean, pardon for the use of that, but the quote unquote, but they have proven that when you compare warfarin and the emptying problems with warfarin and the frequent monitoring that we require. And when you compare with the newer oral anticoagulants, it is cost effective. But for me, if my patients are regular and they are coming back with a good INR, a therapeutic range of 65%, that's what almost the trial has shown, I will still opt for that. But there are instances when I switch over to the newer oral anticoagulant, but not in the setting of ACS.
Dr. Mohanan, where do you think the research will go? You gave us a very good review, 2 antiplatelets and 1 anticoagulant. We have the data, we know. Do you think in the future it's likely that we may drop 1 antiplatelet and have 1 anticoagulant and 1 potent antiplatelet?
You said it absolutely right, sir. I think even the Danish registry data has shown that. If you do a PCI and combine an oral anticoagulant with aspirin and clopidogrel, you stop aspirin at the end of 4 months. And you can just continue only clopidogrel and warfarin. So if your patient has an atrial fibrillation with an ACS, you can drop aspirin at the end of 3 to 4 months. It may also depend upon your type of stent that may use. If you use a second generation stent, all the more easier. But as Professor Satyavan Sharma said, that is the thinking now. Avoid the triple antiplatelet drug. 3 is busy. So don't go with the 3 drugs for a longer time. You keep company with this again double, because it causes excess bleeding for a shorter time and then switch over to the 2 drugs.
Thank you very much, Dr. Mohanan.
Thank you very much, Dr. Mohanan. That was really very informative.